Good afternoon. The presentation will cover two important topics, and we have amongst us very eminent speakers in the form of Dr. Madhuchanda Kaur and Dr. Vijay Ghosh. The first topic will be cancer therapy and heart. We have, as clinicians, have got the experience that clinical conditions like carcinoma of the breast, like bronchogenic carcinoma, other associated malignancies sometimes affects heart. We also get few cases of at least cardiac myxomas, and majority of the things, many times we do encounter problems of chemotherapy-induced cardiac illnesses, drugs, alkylating agents, like and anthracycline group of drugs. They produce various forms of cardiac toxicity in the form of pericarditis, myocarditis, cardiac failure, and even different forms of cardiomyopathy. We will all gather this knowledge from Dr. Madhuchanda Kaur. Mrs. Kaur, please.
Good afternoon. In the year 2000, this lady entered my office with breast cancer. Mrs. A.P. She was a widow with a child 4 years old. After diagnosis, we treated her with the best of treatment that was available. In the year 2019, this lady started having dizziness, and she fainted one or two times getting out from the bus. She was diagnosed with bradyarrhythmia. She had received anthracyclines when she had breast cancer, and now, just 20 days back, she was put on pacemaker. So, ladies and gentlemen, this is a very important topic for today, cardio-oncology, a new discipline highlighting the importance of cardiotoxicity with anti-cancer agents. So, there has been a lot of advances in the rising number of cancer survivors, a huge burden projected by 2025, and cancer patients are at higher risk of heart disease because they have cardiotoxic medications. So, as oncologists, our main aim is to find out a balance between the oncologic efficiency and the cardiotoxicity through various types of research. So what is cardio-oncology? It is an interdisciplinary field of medicine for studying the molecular and the clinical alterations in the cardiovascular system due to the host of all these therapy, chemotherapy, radiotherapy, etc. And efforts are to treat and prevent cancer therapy related cardiovascular problems because we have to treat them. So what best we can do by preventing the cardiotoxicity, that is the main aim of cardio-oncology. Like any other patient, a cancer patient also is subjected to all the risks of heart disease like hypertension, diabetes, the lifestyle factors like smoking, obesity, and we have a history of heart failure, MI. So all these are high risk. And of course, the treatment that we offer that adds to the burden of the risk. I'll show you two exemplary cases, all real life cases. A 20-year-old male presenting with dyspnea at the emergency. He had received anthracycline for acute myeloid leukemia when he was 3 years old. There has been no routine cardiac follow-up during his survivorship. But the last decade, he has been having occasional exertional dyspnea, 35% ejection fraction complicated by atrial fibrillation, put on left ventricular assist device in even later heart transplant, a very rich person's son, but ultimately died at 36 years. So this is an example of lack of cardiac surveillance. He never came for any follow-up after he was cured of his AML, and did not have any cardiac surveillance. This is the benefit of cardiac surveillance. A 57 years old female referred to cardio-oncology clinic with mild tachycardia. She has just completed her 4 cycles of chemotherapy and targeted therapy of anti-HER2 trastuzumab, which is also cardiotoxic. She is asymptomatic, but the LVEF has decreased from 60 to 49%. The global longitudinal strain decreased from 20% to 17%. Carvedilol started and the LVEF has improved and GLS has normalized. So this is the benefit of cardiac surveillance. So friends, what are the cardiovascular adverse events with anti-cancer drugs? A host of things can happen. like hypertension, coronary artery disease, bradyarrhythmia, tachyarrhythmia, QT prolongation, valvular disease with radiotherapy, but we will limit our talk in this limited period to myocardial dysfunction and heart failure. So this is known as cancer therapeutics related cardiac dysfunction, CTR-CD. The LVEF drop in symptomatic of more than 5% is enough to qualify as CTR-CD, or a drop in LVEF beyond 10% with some drugs and 20% with some other drugs, or a total LVEF less than 55% or 50%. So this is the definition as per the European Society of Cardiology and the European Society of Medical Oncology. These are all the potential cardiotoxic drugs, all of you know them, the anthracyclines, ifosfamide, cyclophosphamide, the taxanes. But what I want to highlight is we are using a lot of oral targeted therapy. They are very innocuous, but look, they have so much of cardiotoxicity, pazopanib, imatinib. So don't think just because you're taking an oral drug, you don't have to have a cardiac surveillance. All these are very important. So what are the mechanism of cardiotoxicity in these patients? Basically, they are the oxidative stress due to high collection of calcium in the cytosol. So in a nutshell, this is the reason or the pathomechanism. So initially there is myofibrillar disorganization followed by apoptosis, as you know, and gradually there is myocyte necrosis. So it becomes irreversible as time goes on. What are the varieties? Basically, there are two varieties. Type 1, the anthracycline, type 2, like the anti-HER2 trastuzumab. Here, there is irreversible myocardial death of the myocytes, cardiomyocytes. Here, there is dysfunction. So, generally, this is reversible, this is irreversible. There is a cumulative dose in this type of toxicity, but there is no cumulative dose in the type 2 toxicity. So, this is what I said. Basically, anthracycline is the role model of cardiotoxicity, and they inhibit this very important enzyme, topoisomerase 2B, and hence there is irreversible damage of cardiomyocytes with mitochondrial dysfunction. The cumulative dose that is cut off of around 300 milligram per meter square, but there is a lot of inter-individual variability. All anthracyclines are not the same. There are different varieties with a different cutoff. The relative cardiotoxicity is different with these. So what really happens when you have an anthracycline? You can have an acute onset LV dysfunction just after chemotherapy. You can have a chronic progressive type within 1 year, partially reversible, and this is the most dangerous type that can occur decades after you receive anthracycline, like in my patient which I showed you in the beginning. This can occur, and this is chronic progressive more than 1 year after completion of chemotherapy, and this is irreversible. We come to the type 2 CTR-CD. This is reversible, no cumulative dose, no ultrastructural change in the myocardium, and the beauty is that you can re-challenge with the offending drug once your ejection fraction normalizes. So this is what happens with trastuzumab. 20% only have a lack of reversibility. Around 80% they recover from that acute toxicity. So coming to the methodology for diagnosing or having surveillance with cardiotoxic medications in cancer patients. Most commonly used is, of course, echocardiography. This is having one limitation, that it is observer bias. Muga scan was very much used in nuclear medicine before, now limited use because it cannot give you any structural information. Cardiac MRI is very, very good because it can diagnose myocardial fibrosis, but you know it's very costly, not widely available. And the cardiac biomarkers like NT-proNB, proBNP, and the HS troponin, these are not having any evidence for surveillance in the different trials of cardiotoxic medications in cancer. So, what imaging techniques will we adopt to detect cardiac dysfunction? If you are following up these patients, if you have the chance of using 3D ejection fraction, that is superior to even cardiac MRI. I can tell you in my institution, I don't have any facility for this. This I have taken from the research studies. And as I showed you before, the longitudinal strain pattern has been established to be much superior to the ejection fraction in patients who have received cardiotoxic medications and you are following them up. Cardiac MRI is very good if you have the facilities. Why? Because it identifies all these changes in the myocardium like edema, fibrosis, and I showed you that anthracycline, it is mainly a mitochondrial damage, a dysfunction, gradually leading to irreversibility because the myocytes will ultimately die after apoptosis. Whereas in trastuzumab, anti-HER2, HER2 is a target on the cells of the human body, human epithelial origin, and if you have an anti-HER2 drug that you are using, it will also cause some toxicity in the cardiomyocyte by oxidative stress. But this oxidative stress that it creates is reversible. So in these patients also, you have to do a 2D-EF to follow them up. Once it normalizes, you can re-challenge with the drug. Cardiac MRI actually identifies all these structural changes, whether it is edema, which is reversible, or whether it is fibrosis that is not reversible. Remember, anthracycline causes more of a myocardial dysfunction like lowered ejection fraction, whereas anti-HER2 trastuzumab causes more of a dilated cardiomyopathy that reverses. What is the treatment? ACE inhibitors, ARBs, beta blockers, I don't have to tell you all these. These are actually recommended in the symptomatic patients. There are a lot of prevention strategies like enalapril, carvedilol that have been used in these prevention strategies. ARBs, ACE inhibitors or beta blockers have no effect on the trastuzumab related cardiotoxicity. All these ARBs or enalapril, carvedilol, they have some data in anthracycline related cardiotoxicity, and the very important drug that has come up in the last decade is dextrazoxane, which is a cardioprotectant that can be used if you have a cumulative dose of doxorubicin that is more than 300 milligram per meter square. So friends, there are lots of ongoing trials globally to find out how we can prevent cardiotoxicity with the use of statins, with the use of in patients who are receiving anthracycline. The results of these are not yet out. The PREVENT, STOP CA, Sonar actually uses the GLS, the longitudinal strain pattern, to do a surveillance in the patients who are receiving chemotherapy with cardiotoxic drugs. This is one of the most important prospective trials that will show whether the GLS actually is better than ejection fraction. So ladies and gentlemen, I come to the end of my talk. I pay my respect to the revolutionary change in hyperdrive that led to the birth of comprehensive cardiovascular disease clinic in collaboration with the oncology clinic. So cardio-oncology started in the MD Anderson Cancer Center in July 1st, 2000. It is a very full comprehensive program to diagnose, treat, manage all CVD in cancer patients and the survivors. It has become so important that now we need more specialists with certified training in cardio-oncology. And this was one of the biggest summit on cardio-oncology held recently, with all these very important international societies contributing to the data that was generated from this meeting. Thank you for the very patient hearing, and my time is already up. Any question?
If there is any one or two question to Madam. Now I have one question.
Not much related to cardiology, I can't answer.
We regularly do encounter this problem. Now whether giving medication to protect heart and to continue the chemotherapeutic agents which are causing cardiotoxicity, whether that is rational or we are to, for the time being, withheld.
Okay, very important question. See, I have stated this. If you want to prevent cardiotoxicity, then you have to start it from the day one when you are using that drug, not when they develop, because once they develop, say, anthracycline toxicity, you cannot use that drug. But trastuzumab is one such drug where even after the toxicity, you can stop the drug for some time and re-challenge later on. So these are the very important drugs that have evidence-based, enalapril and carvedilol, whether they can actually prevent the ejection fraction decrease. So that is the way to prevent cardiotoxicity with such medications. Yes, Amulda had one question. Oh,
So, mic, please.
Thank you, Madhuchanda, for highlighting some, I would rather say, emerging area of internal medicine. Many patients are having the anti-cancer therapy and also radiotherapy. They are prone to develop the LV dysfunction. You have rightly pointed out that even when the ejection fraction is normal, this is the protocol of each and every oncologist to undergo what you have suggested. We also suggest the GLS.
yes.
If the GLS is 15% minus 15 or below, then it is better to go for, we should be very cautious regarding 2 or 3 drugs. When the breast cancer, HERS therapy, and also anthracycline group of chemotherapy agent. And then you oncologists, you know that what are the drugs should be used in such situation. And you also, there are 2 drugs, age-old drug like enalapril, it is given when GLS is lower.
Yes.
GLS is a reflection of the systolic function even when the ejection fraction is normal. And also candesartan, by some trial, it is superior. There are, I think, the enalapril and the beta blocker, particularly some trials are with the carvedilol. These are the drugs which you can use, but it has never shown that it can reverse the cardiac changes which has been already caused by the either the radiotherapy or the anti-cancer therapy. Thank you.
Yes, these are all preventing from the day one. And candesartan was shown to be better than beta blocker in this trial. So my main aim was to sensitize the physician population that this is a very important new stream in oncology and cardiology, and collaborative work can actually help us with a lot of research in this field. Thank you.
Okay, thank you to Madhuchanda Kaur. We are passing to the next topics. Our next topics is glucagon in diabetes. For last long years, we know it is well established that the pathogenesis of the type 2 diabetes is insulin resistance and subsequent destruction of the beta cell leading to the insulin deficiency. Both of these mechanisms are responsible for hyperglycemia in type 2 diabetes mellitus. But it is also well known that there is a rise in glucagon level in the diabetes patient. But this glucagon has not given any importance until recently when gliptin-based treatment has been advocated in the management of diabetes mellitus. So pathogenesis, pathophysiology, and also the pathogenesis in the role of glucagon in the type 2 diabetes mellitus is now new recent topics in diabetic in the research area as well as in the advocation of therapy. So Dr. Sujay Ghosh, the eminent speaker, will talk on these topics, glucagon in diabetes. Okay, thank you, sir.
Thank you, respected chairpersons. At the very outset, a big thank you to the organizers having given me this wonderful opportunity to interact with you. As correctly pointed out by the honorable chairperson, that we've thought of that glucagon and insulin are probably 2 sides of the same coin. But just like in Sholay, both the sides of the coin are actually doing the same thing. When you talk about either insulin or glucagon, both of them are the same side of the coin in the pathophysiology of the disease. So what was thought to be a unihormonal disease, that is type 2 diabetes, we now realize it is essentially a bihormonal disease, where you have both an alpha cell dysfunction as well as a beta cell dysfunction, wherein you have deficiency of one and an excess of the other, which essentially leads to hyperglycemia and type 2 diabetes. So this is going to be my flow of talk. I'm going to talk a little bit about the glucagon physiology, the role of glucagon in type 2 diabetes, incretins and glucagon, and of course, the therapeutic implications of glucagon. So long ago, the islets of Langerhans were isolated, And what's important to know is if you look at the proportion of the alpha cells, it's almost similar to the amount of beta cell that you would normally have in the islets. And what's also important is you just can't simply have alpha cells and beta cells. You have to have a communication within the islets amongst the alpha and beta cells, because when you're doing, say, islet transplantation, this part is not taken care of. That's the interconnection between the alpha and the beta cells. So a little bit about the basic physiology. There's a gene which is the pre-pro-glucagon gene, which is spliced into numerous products including glucagon and GLP-1. And glucagon receptors are found in numerous areas including the liver and the brain, apart from pancreas, heart and kidney. So if you look at the very basic of how does glucagon get secreted, these are probably the most important stimulants. And what's important is this huge amount of paracrine signaling. You know, particularly when you're talking about, say, SGLT2 inhibitors and hyperglucagonemia, it's probably more of a paracrine effect rather than a generalized endocrine effect of the SGLT2 inhibitors, which actually cause increase in glucagon. Now, our respected chairperson was talking about, you know, that we've only recently understood how important glucagon is. But if you go back into medical literature, this is New England Journal of Medicine 1970. That's when they first thought, you know, the alpha cells might be having some role in the pathophysiology of diabetes, which obviously, because unless and until you have a therapeutic target, you know, we don't talk about things. Researchers don't talk about things because it's not fashionable to talk about things which does not have clinical implication. And when you're talking about alpha cell dysfunction, there is either an absolute or a relative increase of glucagon in the fasting and the postprandial state. There is lack of glucagon-induced suppression in hyperglycemic condition, and there might be impaired secretory response of alpha cells to low glucose levels. And in the postprandial state, the hyperglycemia could well be having a major contribution by hyperglucagonemia. And when we talk about the GLP-1 analogs or the GIP or the GLP-2, they all suppress the glucose levels by lowering the glucagon levels. That's the predominant mechanism of action. Now, I would like all of you to concentrate only on this one slide for at least a minute or so. Conventionally, what have we been taught? In type 2 diabetes, you have beta cells, and we've been taught about beta cell death. So over a period of time, the beta cells will die out. The beta cell, in this particular research, which is now being supported by a lot of other research, is now clear that the beta cells don't die in type 2 diabetes. They get transformed into something else. So it's not simple cell death. It is shown that there is something called de-differentiation. So the beta cell gets de-differentiated into an alpha cell. Now, why is that important? Because now if you can find a therapeutic mechanism by which you can do a de-differentiation of the alpha cell into a beta cell, you might be able to find a cure or management for type 2 diabetes. This is a seminal publication from New England Journal of Medicine, and there's a lot of pathways which we can talk about, including the FOXO pathway, by which actually in animal models the alpha cell has been utilized to re-differentiate into a beta cell. Now, in type 2 diabetes, when you give someone GLP-1, the glucose level goes down, the insulin level goes up, but interestingly, see down there, the glucagon level goes down. So glucagon has a very important part in the pathophysiology of diabetes, and this is again shown in a graphical manner of what happens to the GIP. When you give GIP infusion, you can see the insulin going one way and you can see the glucagon going down the other way. And what's also important is, you know, in type 1 diabetes, what do we say? You know, it's only the beta cell that's gone, and that's the reason why you have type 1 diabetes. This is a mouse model study in which they show that if you knock out the glucagon receptors and then you take out the beta cells in the mice, you no longer develop type 1 diabetes. So it's not just a simple lack of beta cell and insulin that will cause diabetes. Along with that, you will have to have something wrong with the alpha cell in terms of its function for diabetes to happen in the first place. So if you again now look at glucagon, we seem as if we are blaming that everything that glucagon does is bad. That means hyperglucagonemia is bad for you, right? But we've now realized that glucagon itself might be having some good effects as well. Now, why am I highlighting this? I will talk about it when I talk about the newer drugs that are coming, where we can probably use glucagon receptor agonist in management of type 2 diabetes. However paradoxical it might sound, glucagon receptor agonism also might have some beneficial effect. And that beneficial effect is predominantly by increasing energy expenditure. Now, in a hypoglycemic situation, glucagon has certain role. In the pathophysiology of hypoglycemic situation, there is some certain other role. So, in a hyperglycemic milieu, when it happens because of hyperglucagonemia. There might be weight loss and there might be some benefit in case of NAFLD. You know, in hypoglycemic state, the hormone that prevents you from dying is probably glucagon because it causes recovery from hypoglycemia, and glucagon is used for management of hypoglycemia. So this is the positive thing that I was talking about. Glucagon increases energy metabolism and expenditure and might cause weight loss. And that's probably the mechanism by which partially the GLP-1 receptor analogs actually work. In terms of what happens in NASH and NAFLD, we don't know what's the cause and what's the effect, but probably hyperglucagonemia is actually a beneficial thing that happens in management of NAFLD and NASH. So that glucagon pathway will probably increase expenditure of some of the metabolites that accumulate in the liver. That is something which might be beneficial. So glucagon benefit in NAFLD, it can cause weight loss, lipid metabolism can be modified, and general metabolic state might also be modified. Glucagon in hypoglycemia, you're all aware of that, if you do not have glucagon, endogenous glucagon levels, recovery from hypoglycemia is going to be delayed, and the hyperglycemic response of counter-regulatory hormones that occurs, whether it's the growth hormone, whether it's the cortisol, it's all actually mediated through the glucagon pathway. And in individuals where you have an early loss of glucagon response, that might lead to hypoglycemia unawareness and severe hypoglycemia, which you might not be able to manage. So if I can again summarize glucagon secretion abnormalities, it will be a problem if you have high glucagon levels as in type 1 diabetes, advanced type 2 diabetes, or in the pathophysiology of diabetic ketoacidosis. However, the paradoxical glucagon response to meal might actually lead to postprandial hyperglycemia. So I'll skip some of the slides because I just want to concentrate on the therapy areas as well. Now, I've already talked about how the alpha cells are equipped to adapt and survive in metabolic stress. Therefore, in type 2 diabetes, the beta cell becomes an alpha cell and stays like that. Could this lead to preserved alpha cell and thus hyperglucagonemia in type 2 diabetes? We don't know, and whether we can go for re-differentiation. In terms of the NAFLD, I've already talked about that there might be hyperglucagonemia, but glucagon itself might actually be good for NAFLD for management. So is it possible that you are having NAFLD where the glucagon levels are high and yet you are having the bad metabolic effects? That's probably because just like you have insulin resistance, in the pathophysiology of NAFLD you might have glucagon resistance. So what about glucagon and diabetes therapy? Let us look at each of the drugs, just one-liners because I have only about 2.5 more minutes to finish. Metformin suppresses hepatic glucagon signaling by decreasing production of cyclic AMP. That's probably one of the most important mechanisms by which this mystery drug metformin actually works. If you talk about insulin and sulfonylureas, they inhibit glucagon secretion. If you look at glimepiride, in one of the studies it was shown that there might be even weight loss with glimepiride, and one of the postulated mechanism is probably through the glucagon pathway. Pioglitazone and the TZDs do not have any effect on glucagon. Amylin mimetics, that is pramlintide, is a drug which is not used in India but used elsewhere, decreases glucagon. We all know about the DPP-4 inhibitors and the GLP-1s. I think I will not waste time because you would have had a million talks on GLP-1s and DPP-4 inhibitors. Just a few words about it. That DPP-4 inhibitors versus sulfonylureas, if you particularly compare, the glucagon response is much better modulated by the DPP-4 inhibitors compared to sulfonylureas in spite of possible similar glycemic control. In terms of the GLP-1 analogs, they also suppress the glucagon level, and that's one of the most important mechanisms of action. And even the GLP-1s the mechanism of weight loss is probably through the glucagon pathway. In terms of the SGLT2 inhibitors, we are all aware that it causes hyperglucagonemia, and that results in two things. Number one, 50% of the clinical efficacy of SGLT2 inhibitors is blunted because of the hyperglucagonemia. And secondly, it is the cause why you have euglycemic ketoacidosis in type 2 diabetes when you use glucagon. Sorry, I can't show you the pathway. Now, when you are talking about newer drugs that are going to work through novel glucagon pathway, I'll just list 3 drugs. Now, we have been using DPP4 inhibitors and we have been using GLP-1 analogs. But there are now other injectable agents which you can use. And of them, the second and the third are probably going to be very important. The first is already has got a name now. It's called tirzepatide. It's a twin creatine which uses both combination of GLP-1 and GIP. This is a product of Eli Lilly, which is already undergoing clinical trials in India as well, which shows huge amount of HbA1c reduction of 2.4% and with great weight loss. The second is a molecule which AstraZeneca is actually developing right now. It's called Kodutide. It's an oxyntomodulin-like peptide which has got a glucagon receptor agonist property in addition to a GLP-1 property. So now you know, if you have a molecule which will stimulate the glucagon receptor and increase energy expenditure and cause weight loss, whereas the GLP-1 analog will inhibit the bad effects of glucagon, then you are having a combined effect where the good bit of glucagon is utilized and the bad bit of the glucagon is suppressed. The third is another molecule which the Japanese people are under development, where they are using a drug which is a glucagon agonist, a GLP-1 antagonist, and a GIP antagonist. So 3 new drugs in pipeline. And finally, this is the study that I was trying to talk about. I've already talked about in type 2 diabetes, you have de-differentiation of beta cell to alpha cell. This is one very early report in mouse model study where they have de-differentiated the beta cell back into the alpha cell back into a beta cell and cured diabetes. So what about glucagon and hypoglycemia? Just quick words, because this is something that you and I use in clinical practice. You have 2 commercially available glucagon kits, and it takes about 10 to 15 minutes to act. Probably I should have given it at the beginning of the talk so that you did not develop hypoglycemia, and the effect lasts for about 30 minutes, and vomiting might occur because of the GLP-1 like effect of glucagon. And therefore, you should keep the patient in the left lateral position, because otherwise the patient might aspirate if you have somebody who has developed hypoglycemia. Recovery from a severe hypoglycemic episode depends on a lot of things. I'll talk about that. And there are certain signs and symptoms which may persist for several hours. These are situations where you have to be aware of. If somebody has hepatic dysfunction, if somebody is having alcohol for a long period of time, or has had a sulfonylurea, this is probably not going to work in terms of management of hypoglycemia. And now, instead of an injectable glucagon, FDA has now even approved a nasal glucagon. So you have a patient who's developed hypoglycemia, you can give a nasal puff of glucagon and reverse the hypoglycemia. And now we have another stable solution, because the other glucagon injection that I talked about, there's a lot of problems in storage of that particular glucagon and also very short half-life. So shelf life. So you can't keep the glucagon, keep buying every 6 months. When am I going to have a severe hypoglycemia? This is going to have a much longer shelf life. This particular glucagon analog, which is called dasiglucagon. So I've already highlighted the positives and the negatives, both in hyperglycemia and hypoglycemia, and I shall stop there. Thank you very much.
Thank you, Dr. Ghosh. Very nice presentation. So glucagon suppression is becoming the newer therapy in the management of diabetes mellitus. Any questions from the audience? Hello, Mike, please.
Yes, sir. Agreed, sir. Sir, I was given 17 minutes to speak, then it came down to 13, and today I saw it was 10. Because so I actually had to keep on cutting down on various aspects. It's not possible to talk about, but definitely there are studies to show that it can be cardioprotective as well. Agreed, sir.
No, this is important in the sense, SGLT2 inhibitors particularly have...
So that's one of the postulated mechanisms.
Yes,
agreed.
Just one comment. When we differentiate, we go to the progenitor side.
Right. Right. Ma'am, there are five different cell differentiating transcript molecules. Now, depending on certain pathophysiological processes, which I also don't understand very well, there's a molecule called FOXO1.
Fibroblasts and others.
FOXO1. That's probably the key molecule which because all of the cells, even in the pancreas, in the islet cell, are in a progenitor state. Because we were taught as if you develop beta cell at birth or at the time of birth, and then you no longer grow any new beta cells. That is not true. There is cell renewal of beta cells all through the life in all individuals. Possibly the rate of renewal goes down. So we have progenitor cells within the pancreas itself. So what will happen, whether it will go to the pathway of the alpha cell or whether it will go to the pathway of beta cell, when this regeneration is happening.
So from de-differentiating to the progenitor, they again have to differentiate into that.
Yes.
Thank you.
Thank you, sir.
I am ending this session today. Hello, Dr. Ghosh, please come here to take, and Dr. Madhuchanda Kaur.
So, Chairman is being felicitated by to Dr. C.K. Jana, Professor and Head of the Department of Medicine at GCOT, and Dr. Professor N.M. Bishas,